With the free paper session on trauma, and I'll request the participants to be ready with that. Instructions, I can just read it out. Each paper has to be 5 minutes. Changing of the presenting author is not allowed. And each specialty we have to choose one. So is that we have to make the results here?
Yeah, we have to make the result here.
Okay, good. So can we start with Ankita? Yeah. Is there anybody else out of the judges? Both of us? So you are not a ratified member? Okay, fine. That's fine. So you can start with it.
Hello. Good morning, everyone. Myself, Dr. Ankita Gogoi, and I'm here to present a case report titled Intra-Orbital Wooden Foreign Body Mimicking Lead Mass. The authors have no personal, financial, or institutional interest. Intra-orbital foreign bodies are a global injury and occur with a frequency of 1 in 6 orbital injuries. However, an intra-orbital wooden foreign body constitutes a relatively rare ocular trauma. The clinical outcome depends on the severity of the initial trauma, the location of the intra-orbital wooden foreign body. Visual loss typically occurs as a result of the initial injury and the complications. They carry the risk of damaging the orbital contents, intracranial extension due to conical shape of the orbit. They might also give rise to different types of complications such as granuloma, orbital cellulitis, orbital abscess, osteomyelitis, periosteitis, or chronic fistula. The diagnosis and management of intraorbital wooden foreign bodies are difficult as the history and external signs of injury are often scarce or absent. There may be a long delay between injury and the presentation, and the foreign bodies may be missed by the regular imaging modalities. So here's my case report. A 45-year-old female presented with a left lower lid swelling for the past 6 months, which was gradually increasing in size, and for the past month, it was also associated with pain, watering, discharge, and diminution of vision. Uncorrected visual acuity was 6.9 in the right eye and 6.24 in left eye. Ophthalmic examination of left eye revealed a tender circumscribed hard swelling in the left lower lid associated with conjunctival congestion and marked chemosis and restricted extraocular movement in lateral gaze. Her anterior chamber was quiet and pupils are reactive. Ophthalmic examination of the right eye was unremarkable. She gave a history of trauma to the left eye 1 year back by wooden broom. However, as she was asymptomatic, no treatment was taken then. There was no other relevant surgical, allergic, or medical history in the past. So this is the picture showing a circumscribed hard swelling in the left lower lid region. It is associated with conjunctival congestion and marked chemosis in the lateral half. The extraocular movement was restricted in the lateral gaze. The patient was evaluated with CECT orbit, and it revealed a linear hyperdense structure 2.3 centimeter in length and 3.7 millimeter in thickness in the left lateral rectus with surrounding inflammatory changes. Her CBC RBS were within normal limit. So this is the CT scan showing the wooden foreign body trapped in the left lateral rectus muscle. The patient was admitted and IV broad-spectrum antibiotics along with topical antibiotic eye drops were started. Systemic analgesics and anti-inflammatory drugs were also given. The foreign body was carefully removed under local anesthesia by a small subciliary incision. Culture swab of the wound was taken. The inflammation gradually subsided and the patient recovered well after the removal of foreign body. The patient was followed up for a period of 3 months, during which her vision improved to 6.6 and she regained full ocular motility. So a wooden foreign body inside the orbit or cranium may be difficult to diagnose, especially in cases of apparently minor trauma. When a patient presents with a history of ocular injury caused by organic materials such as wood, the possibility of retained intraorbital foreign body must be considered, particularly when there are signs of inflammation and limitations of extraocular movement. CT is currently the gold standard for detecting intraorbital wooden foreign body as it is cheaper, easily available, fast results, suitable in children. Wooden fragments not only pose a risk to adjacent structures from physical injury, but also associated with significant risk of infection. A timely exploratory surgery, removal of foreign body with heightened level of attention, post-operative antibiotic prophylaxis and follow-up essential in its management. So, to conclude, high index of suspicion supported by a proactive history, clinical examination, and good quality CT are essential for diagnosing an intraorbital wooden foreign body. Early management is essential to reduce ocular and adnexal morbidity. Early surgical exploration and foreign body extraction greatly influence the visual prognosis and the final outcome. These are my references. Thank you.
Thank you, Dr. Ankita. I think just one thing, did you rule out any fungal infection?
So, the culture swab was taken from the womb.
KOH?
Yes, sir.
KOH also?
GIMSA, GS, culture sensitivity, and KOH, sir. But all came out to be negative, sir.
So she was not covered for antifungal?
Antifungals were not used, sir.
Okay, fine. I think,
Thank you, sir.
Yeah. So we'll go on to the next. Again, intraorbital bamboo foreign body. Presenting author is Dr. Deborah. Yeah, please.
Good morning, one and all present here. Today I'm going to present a case of intraorbital foreign body impinging into roof of maxillary sinus, a case report. No financial interest. The authors have no conflict of interest. Informed written consent was taken from the patient before the presentation. Introduction. Intraorbital foreign body injury is a common occurrence in rural population. It can present with history of injury with visible foreign body, laceration, pain, swelling, dimness, vision, etc. depending upon the mode of injury, severity, and time of presentation. Diagnosis is made based on detailed history, clinical findings, and proper imaging modalities. Case report. 38-year-old male presented to us in casualty with impacted foreign body in left orbit following accidental trauma while working at home. He sustained the injury 5 to 6 hours back. On examination, the rugged external end of the foreign body was seen in left lower orbit, which on palpation was found tightly impacted inside. Ocular motility was moderately restricted in all gazes. Mild proptosis was noted. Supero-nasal displacement of the globe with inferior conjunctival subhemorrhage and chemosis was seen. His vision was 5/60 with 28 mm mercury of IOP. Other anterior segment structures were found within normal limit. CT scan orbit was done and it showed left intraorbital foreign body impinging into roof of maxillary sinus. Here we can see the hypodense foreign body impinging into the maxillary sinus. Other routine blood investigations were within normal limit. Fundus and OCT were within normal limit. On presentation, patient was started on broad spectrum antibiotic, ceftriaxone and sulbactam after IVBD. Injection decadron once daily was given. Topical eye drop with antibiotic eye drop with steroid 1 drop 6 times daily was given with eye ointment at bedtime. Antifungal drop was given 4 times daily. Eye drop timolol was also added, and tafluconazole ODPC was given after LFT was within normal limit. And anti-inflammatory and pain killer was given twice daily. Injection diclofenac and TT was given on presentation. So as the foreign body was impinging into the roof of maxillary sinus, ENT opinion was taken, and we went forward for the surgical removal under LA by subciliary approach, and foreign body which measures about 3 into 1.5 into 1.5 centimeter was removed. These are the foreign bodies that was removed. On post-op day 1, his vision was 6/9 with reduction of IOP and proptosis with full ocular movement restoration. Patient was reviewed after 2 weeks with 6/6 vision with only mild conjunctival congestion and subconjunctival hemorrhage. No fresh complaint or clinical signs were noted on subsequent follow-up. Discussion. Intraorbital foreign body can be a common encounter in a clinical practice in rural areas. However, involvement with paranasal sinuses is not very common. Can occur mostly after penetrating orbital trauma. As Simha et al. In 2010 also reported a case of intraorbital foreign body involving maxillary sinus. Studies have shown that outcome of injuries is better with early intervention and prevention. However, prevention remained a priority to reduce morbidity and complications. The outcome in our case was good as patient presented on the same day of injury and prompt management was done accordingly. Conclusion. In all cases of trauma, detailed history of injury, thorough clinical examination, and Appropriate imaging modalities with high suspicion index is necessary. Early diagnosis and prompt treatment should be done to salvage the eye and prevent its complications. These are my references. Thank you.
Was there any lid defect post-operatively?
Sir, the laceration was repaired and there was not much.
Thank you.
So, thank you, sir.
So we will call upon the next presenting author, Dr. Dilip Kumar Batra. Is he here? Please. Study improvement in stereo acuity following management of traumatic cataract in children. Sorry? So you are doctor? No, this is Dilip Kumar Batra. Who all are here? Okay. Anybody else? Swati. Anybody else? Dilip Yadav, you are saying? Yeah, that is still down the list. Dr. Ekagrita. So we are requesting Dr. Dilip Kumar Batra, and after that Dr. Abhishek, a rare case of corneal tear with intraocular lashes, and Dr. Nitya, a study on efficiency of prophylactic intravitreal antibiotics in preventing traumatic endophthalmitis. So if these presenters are not there, then I'll like to call upon Sashmita Sahu, a case report, large wooden intraorbital foreign body.
Good morning all. I'm here to present a case report on a large wooden intraorbital foreign body. There is no financial support or sponsorship. Coming to introduction, intraorbital foreign bodies are a global phenomenon and occur with a frequency of 1 in 6 orbital injuries. However, intraorbital wooden foreign bodies are uncommon. Intraorbital wooden foreign bodies predominantly affects a male population with a mean age ranging from 18 to 25 years. These vegetative foreign bodies must be removed as it serves as a needles for orbital infection. We report such a case of a large intact intraorbital wooden foreign body which was removed successfully and improvement seen in the ocular status of the patient. Case history: a 25-year Hindu male from Odisha presented to the casualty with a sustained wood penetrating injury in the right eye. He had a history of an accidental fall from the tree on the same day. On examination, patient GCS was 15 out of 15. On ocular examination, we found on right eye visual acuity was perception of light, and on left eye it was 6/9. There was restriction of extraocular muscles in all direction in right eye. On anterior segment examination, there is mild proptosis along with congestion and chemosis. There was sealed corneal tear present with corneal edema. The pupil was dilated and not reacting to light. AC was maintained, and a large wooden foreign body located at the medial canthus. Here it is a picture. It is a picture the patient at the time of presentation. The fundus examination was not possible due to very hazy media, and the CT scan of the orbit was done, and the air density was found in between the middle wall of the orbit and globe. There was no intracranial or nasal cavity penetration, and the globe was intact too. Coming to the management, the patient was hospitalized and injection tetanus toxoid along with intravenous antibiotic and analgesic along with moxifloxacin eye drops were administered. After neurology consultation, the case was planned for exploration. The peribulbar block was given, and under all aseptic condition, with the help of artery forceps, the wooden piece was removed intact. The size of the foreign body was 8 into 3 centimeter. The wooden area was clean, and the gap was closed by retracting the globe medially with 6-0 Weichel suture. Then intravenous ceftriaxone along with diclofenac and pantoprazole and oral fluconazole was given, and antibiotic with steroid eye ointment combination were given post-operatively. Here it is a picture of pre-op and intra-op, and the size of foreign body is 8 into 3 centimeter, and post-operative images of the patient. On day 1, the wound area was healthy and no discharge found. Chemosis and corneal edema subsided. The pupil was dilated and not reacting to light. The vision was still perception of light. On day 3, the mild congestion was present, but chemosis was resolved. And on day 4, the patient was discharged with oral antibiotic, oral steroid, and topical eye drop and eye ointment. Discussion. The retained wooden foreign body may lead to complications such as prolonged suppuration, orbital cellulitis, abscess formation, panophthalmitis, extraocular muscle damage, and even brain abscess. As there is no definite imaging studies, CT scan is usually performed in orbital trauma cases where foreign body penetration is suspected. After excluding the possibility of the metal foreign body, MRI can be performed in an open injury with wooden foreign body. The surgical removal of the wooden foreign body requires extreme caution. Utmost care must be taken to prevent fragmentation of wooden pieces during the extractions. At last, I conclude that 90% of the orbital injury is preventable, so prevention is better than cure, and implementing the appropriate imaging modalities and diagnosis, imaging modality for diagnosis and careful surgical removal of foreign body is critical to minimize complication and a good post-op outcome. These are my references. Thank you.
Thank you, Dr. Sashmita. Just wondering why so many orbital foreign bodies, and that too wooden. Is there any specific reason, and can you prevent these?
So, as prevention, patients need to be more careful.
No, what is the setting under which they get this?
And, mostly they are
Like
from
they
rural and working in fields or
I
that's
think
why.
farming, they
Farming,
bamboo
yeah.
farming and those handicraft with bamboo sticks are there. So that may be the cause of it, because when you cut the bamboo,
Yes.
they may just fall in the speedily. The sharp wound can
Yes.
be done with those things.
Yes.
And the other thing which is surprising is that these wooden sticks, they don't enter the eye. Why? They are just in the orbit. None of these have hit got into the sclera.
In my
Do you have any explanation for that?
no, sir.
No?
In my case, there was no intracranial or
But
nasal
there
cavity
can be,
content.
no?
There can be, but in my case, there was none.
I think they may have closed their.
So you
reflections
said
of-
PL initially, no?
Yes, sir. Perception of size.
Yeah, but then the person retained 6/9.
No, sir.
Huh.
Not in this case.
Not in
No,
this
no,
case.
no.
Last,
Okay,
last.
okay. So probably because I think these foreign bodies are not sharp edged. So that might be the reason that they are not able to penetrate. And then the velocity with which they are hitting the eye may not be that sharp as running iron foreign body or something would be. So those are the things which come to my mind, if that can be the case. Otherwise, it's a good presentation. Thank you. But just wanted to know what else can you do to prevent this? Because these are hazardous, of course.
I think only protective glass is the option which we can
Protective
give.
glass.
No, but I don't know if you can give protective glasses to whole of your population, and that too rural. How can we advocate that, Only thing, correction of glass, refractive error might be important.
If someone is having that,
Yeah, because if you are not able to see the distant objects, you might be at a more risk of getting injuries.
So, but it is a case of accidental falls.
no,
From
because
the
I was
tree.
telling you we can do reflection.
We can do, yeah.
Yes, sir.
Yeah.
Screening for the
One
refractive.
preventive aspect can be that if the person is not seeing clearly, he may be at a more risk of injuries.
Because in this, the left eye was 6/9, so in that eye also may need correction.
Never know.
Yes, sir.
Thanks a lot.
Thank you, sir.
It was a nice presentation. So, if any of the absentees are not there, we'll go on to the next topic by Dilip Yadav. There are two presentations from your side. This is Chief Presenter Dilip Yadav, Profile of Victims of Assault-Related Ocular Trauma
He submitted
in
twice.
North Indian. Is it the same topic?
Yes, same talk.
No.
While submitting, you submitted twice the same topic.
Same here.
Last वाले में भी यही था.
No, but the paper number is different.
Maybe he has clicked twice.
Okay, so if you click twice, you can present it twice. Okay, please come.
And that too, in one case he is not ratified, and this he is ratified. Maybe
Are you ratified? What is your membership number? What is your membership number? Do you know, remember your membership number? When did you get became a member?
2 to 3 months back, I registered. 3 months.
After Bombay conference? Okay, so that means you are not ratified. I think you are all postgraduates, isn't it? So do you know what is ratification? Why after 1 year? Yeah, because most, like all members who apply for their membership, they get ratified in the general body meeting, which happens once in a year during the conference. So if you have not been member before Bombay conference, you are unlikely to be a ratified member. Thank you. If you click twice, you can start.
Good morning, respected chairperson, judges and audience. My topic of presentation is profile of victim of assault-related ocular trauma. There is no financial disclosure. Patients were given written informed consent for use of photographs and investigation reports obtained. Assaultive violence is physical force used by one person to another with an intention to cause harm, injury, or death. It is 11th leading cause of death and 5th leading cause of mortality in USA. Assaultive eye injury is more severe than other ocular injury. Aim of this study is to determine demographic profile, etiology, pattern of clinical presentation, and preventive strategy of assault-related trauma. This study is prospective hospital-based observational study, which is conducted in Rio IMS BHU Varanasi, and sample size is 60. 60 sample size is studied and followed. Patients of all age group with acute assault-related ocular trauma who are under regular follow-up for 6 months are included in this study. Ocular injury older than 1 month and treated in other hospitals are excluded, and also patients who are not under follow-up under regular follow-up for 6 months are excluded from this study. All the general information is specific history are noted down, and vital examination and examination of injured part, like type and extent and severity of injury. Ocular injury like visual acuity, ocular motility, and IOP are properly examined. And most of the victims, around 80% are male, and 53% of them are 16 to 30 years of age, and most of the assault cases are noted during morning and afternoon time, and which is away from home from in 67% of cases. And most common reason is economic interest, followed by political rivalry. A most common weapon used is blunt trauma, followed by sharp object and chemical object. And physical object is most commonly used, followed by chemical and thermal and firearm. This acid case is treated in our hospital, BHU. There is oculofacial injury. And all type of ocular injury is common, like isolated, or it may be associated with facial or cranial injury, and it may be associated with a polytrauma. And a unilateral ocular trauma is most common. Periocular lead injury is most common. It is around 63% cases, followed by globe injury and then orbital injury. This is a case of physical assault by fist. Left orbit of the floor is fractured and soft tissue protrude in maxillary sinus. And this gunshot assault perforating injury noted in post-election time. This is assault by gunshot during robbery. There is multiple metallic foreign particles on face and cornea. This is physical assault by cycle chain. There is scleral rupture, uval prolapse, and hyphema noted. Most of the assault-related ocular injuries severe, then moderate and mild. At the time of presentation, most of the patients have visual acuity less than 3/60, and which rarely improve after final treatment. Conclusion of this study is most of the assault-related ocular trauma is seen in young adults, and most common cause is blunt mechanical trauma. A majority of the assaulty ocular injury are severe in nature, which may lead to blindness. Prevention of assault-related injury is more difficult than other causes of eye injury. There is an urgent need to tackle the economic and social issue of rural males resulting in violence. Legislation limiting the proliferation of firearm and alcohol consumption can prevent the severe and fatal assault injury. And finally, I am very much thankful to my mentor, Dr. R.P. Maurya, who allowed me and present this topic on ocular trauma. Thank you.
Thank you. So you say, is it the first presentation to your casualty, or these patients were referred to you?
No, sir, this is first presented to my hospital.
To your BHU IMS?
Ji, sir.
So you say they are more common in morning and afternoon,
Ji, sir.
and more related with alcohol intake.
Alcohol intake, yes, sir.
So do they start in the morning only?
No, sir. This is more common in.
Huh?
No, sir, it's not.
No, because in Punjab it is the other way around. They'll come at night only after assault.
Morning, basically interfight, that is more common. I don't think because of
Yeah,
alcohol
but
it won't be.
you had a lot of people with alcohol intake, isn't it?
Yes, in our hospital there is a lot of patient came with alcohol in.
So
pediatric
did
also.
they test alcohol levels at presentation,
No,
or it was just a history?
not history. At the time presentation, they already drunk. Sir.
No. Do you check the blood levels,
No.
or do you do any kind of breath test, or it is just by history?
Just by history, sir.
So these cases must all be medico-legal cases.
Yes, sir. Most of the cases are motor.
So how do you deal with the medico-legal implications of this?
Sir, we inform the police and then start treating patient. And then
So all these patients were seen by you?
no, sir. This study is already conducted in my hospital by my mentor, Dr. R.B. Maurya, and I am part of it.
You are part of that study.
Yes, sir.
So what was the final outcome about visual acuity?
So, sir, in most of the cases, sir, visual acuity is less than 3/60, and final outcome is not very much improved after study. So, prevention is more important in this type of.
Can you tell us what interventions were done in these patients?
Sir, like intervention, we treated this
Because
patient.
more than 50% had severe injury, isn't it?
Yes, sir.
So,
I can't do very much in the
no, if there is a open globe injury or a blunt trauma case, were there any surgeries done in these cases?
If there is cornea tear or scleral repair, then we repair in emergency on emergency basis.
Or any follow-up vitrectomy or any such surgeries were done? Or were they referred?
So on emergency
Can you
basis,
go back to your slide? Initial presenting visual acuity? No. This one. Visual status
At the time presentation, sir,
Yeah.
in most cases there is less than 3/60 in
these
blindness.
29 cases,
Yes, sir.
it was 3/60. And final also was in
28.
28 cases. So what all interventions were done in these cases?
Sir, we treated, and if there is, it depends on the sir, how much there is injured. If there is a tear or anything else, then we repair the tear, but improvement is not very much.
The whole detailed investigation which you have submitted this patient, like suppose if you have done the repair the tear, then after you have repaired, whether you have followed up the patient with ultrasound to see the status of the retina,
Or any
hemorrhage,
follow-up
any surgical
surgeries, vitrectomies
follow-up.
were done or not?
Yes, sir. patient is following up, sir. If some patients are also referred to other higher center.
So were they excluded from the study?
No, sir. And if, after
No, but these patients followed up with you for 6 months. Because less than 6 months you have excluded.
yes, sir. More
So
than 6 months.
if they are referred
Yes, sir.
to other hospitals for
we try
any
to
further intervention,
That
Yes,
should be
sir.
within 6
wi-
months only.
will they come to you
Sir,
for follow-up?
We try to contact that patient, sir. If they will come, then I include this patient in our study. I try to follow up that patient.
So this is more of an observational study.
Yes, sir.
Yeah, it's basically observational study. Sir was pointing that if you're following the patient, means what is your exclusion criteria? You said we are excluding any patient who is we are including within 6 months.
Yes,
So
sir.
6 months is a good time where you have to follow the patient properly and give the correct treatment.
Whatever
is
management
required,
we can
whatever,
do
if you
for
have to
these patients.
Refer the patient to higher center, you have to refer that during those duration only. But 6 months is a big time for any surgical treatment, if it is at all required for these traumatic eyes. So, sir was referring to those things.
So that's what I'm just wondering, that during this 6 months period where these patients were with you, what all surgeries, what all kind of surgeries were done? How many of these had foreign bodies inside? Inside the eye, intraocular foreign bodies.
All the patients are not seen by me, but the number of patients, I think 10 to 12% have foreign body in. Yes, sir.
Thank you.
Thank you, sir.
Thank you.
Next speaker is Dr. Ekagrata Shukla. The talk is on pattern of oculoorbital injuries following motor vehicle accidents.
क्या यार,
बस एक ही तो हम लोग को mark
एक ही तो मार्क करना है, फिर क्या मार्क करना उसको दे देते हैं बस, खत्म हो गया.
Good morning, respected judges and the delegates here. Myself, Dr. Ekagrata Shukla. I'm presenting a free paper on topic pattern of oculoorbital injuries following motor vehicle accidents. No financial disclosure included, and written and informed consent for the use of photographs and investigations were taken from the patients. Road traffic accident is the 8th most common cause of death worldwide, and India accounts for almost 7% of the total road traffic accidents. With growing number of vehicles, new drivers, poor and congested roads, RTA keeps on increasing. It's the most common source of polytrauma. Orbit is frequently fractured facial bone in RTA. RTA-related injuries are often associated with severe vision-threatening complications. The aim of the study is to study the epidemiology, clinical radiological pattern, severity and outcomes of RTA-related orbital trauma. Methodology, it's a retrospective hospital-based observational study over a period of 4 years. The sample size was 224 consecutive cases of RTA-related orbital trauma. Data we retrieved were demographics, details of accidents like type of road, vehicle, travelers and impacts, injury pattern, body or affected part, type of globe or orbit injury and visual acuity, the therapeutic interventions and the clinical outcome. This table represents the characteristics of patient. So the most of the patients belong to male gender. The age group, most common age group was 16 to 30 years, followed by 31 to 45 years. The most common habitat was from rural, followed by semi-urban. Most of the cases lacked use of protective devices. And most of the cases, if you see for the consumption of alcohol, most cases were in consumption of alcohol. So when we go to the data of place of accident, most cases were from village. In the section of type of road, the most cases we saw were from pitch road or highway and followed by the kacha or soil road. In type of user, the most cases we saw were using 2 or 3 wheelers vehicles, 2 or 3 wheel vehicles, followed by 4 wheel vehicles. Number of vehicles involved in most cases were two vehicles involved in RTAs. In fate of accident, most of the cases we saw were in cases with collision with person or vehicles or objects. Impact direction, most cases we saw were of frontal impact followed by side impact. Distribution according to the type of trauma and number of orbital wall fracture. So the most common type of orbital trauma we saw was maxillofacial or orbital trauma, followed by cranioorbital facial trauma. And number of orbital wall fracture, the most common were two wall fracture and followed by single wall fracture. These are the few pictures of the victims of road traffic accident having multiple displaced comminuted fracture of orbital walls. It's a case of a right eye pan-orbital fracture in RTA, and it was repaired by multidisciplinary approach using titanium many-plate fixation. These are pre-operative and post-operative picture of the patient. This is a case of a left eye pan-orbital wall fracture in RTA. Pre and post fixation pictures. So the initial and final visual acuity. So it all depends on the present the final visual acuity mostly depended on the visual acuity at the presentation after RTA. So among good vision, there were most of the patient who presented with good vision at presentation showed improvement after treatment. Final visual acuity according to number of orbital wall fracture. The data shows that in case of the single orbital wall fracture, the good vision with single orbital fracture, there were this much percentage of patients, while the most common fracture being two orbital wall fracture, there were only 17% patient with good vision. In case of visual impairment, most cases came under pan-orbital wall fracture, and no vision patients. These data suggest that how many walls fracture leads visual acuity and comparison of number of wall fractures. Conclusion, RTA is a major cause of orbitofacial trauma, and orbital fractures are often complex and multiple in nature. Degree of visual impairment is directly proportional to the number of orbital wall fracture. Management of road RTA trauma need multidisciplinary approach, and the early referral and appropriate intervention will reduce the blinding outcome. Awareness about the traffic rules and safety measures should be disseminated among the rural population. These are my references. And thank you to my mentor, Dr. R.P. Maurya, sir.
Thank you.
Thank you.
Thanks. So these surgeries were done by the ophthalmology team or the plastic surgery team?
Sir, it was a multidisciplinary approach actually. We also included oromaxillofacial surgeons and plastic surgery teachers. We referred them to the
So
department
those
there.
Mostly these things must have been done under
Ji, sir.
general anesthesia.
We just followed the patient for their visual improvement and.
Extraocular movements?
Ji, sir. All the profile we follow. Once the patient is admitted, we check for the visual acuity, extraocular movements, RAPDs, whatever, and then if all the details, demographics, and then we follow with the same data.
Was there any seasonal variation in
Sir,
the injuries?
Sir, we did not take that parameter, but
Number was used, like big
220.
No, because like
sir,
these fog and
with my experience, winters, most of the cases were
because
winters.
if
We
it
did
is
not
early
include
morning, fog or
Yes,
late
yes, sir.
night or
Ji, sir.
those.
Yeah, it does occur, sir.
Thank you.
Thank you, sir.
So now we'll call upon Dr. Swati Gautam, profile of pediatric ocular trauma in teaching hospital. Five minutes last.
We have 15 minutes left.
जैसे रेलवे वाले लेते हैं ना, इतने जोनल रेलवे से 15 मिनट लेट मिली गाड़ी तो आगे 15 मिनट लेट देंगे हम.
Good morning, respected chairpersons, judges, and audience. Topic of my presentation is profile of pediatric ocular trauma in a teaching hospital. I have nil financial disclosure. Parents of all children were written informed consent for the use of photographs and investigation reports obtained. Eye injuries are the leading cause of acquired monoocular blindness in pediatric age group. It accounts for approximately 8 to 14% of total eye injuries in children, approximately 1.6 million blind people due to ocular trauma, and 2.3 million being bilaterally visually impaired. Pediatric eye injuries have special concern because it is prone to amblyopia. The aim of our study is to analyze the clinico-epidemiological profile and treatment outcome of ocular injuries in pediatric age group. This is prospective, observational, hospital-based, non-comparative study over a period of 4 years in the Department of Ophthalmology. Children of less than 15 years of age with acute ocular trauma and receive regular follow-up up to 6 months are included. Superficial injuries such as conjunctival, foreign body, ocular injury, greater than 1 month duration, injury to blind eye, patients who haven't received complete follow-up above 6 months, and comatose or unconscious patient were excluded. We analyzed demographic profile, age, sex, date, place and time, injury profile, cause of trauma, type of trauma. Clinical presentation include laterality, size and structure, involvement. Treatment outcomes include initial and final visual acuity, and prognostic factors were analyzed. Out of 120 patients, 63.3% were male, the rest were females. Most common age group include 11 to 15 years, that is 43.4%, followed by 6 to 10 years, that is 36.6%. Most common place of injury is at home, 48.3%, followed by playground, school and road street. Maximum 73% eye injuries were of by mechanical injuries, and 39% by non-mechanical are non-mechanical. Mechanical injuries include wooden objects, 31.7%, followed by stone and metallic object. Non-mechanical injuries were caused by thermal, that is 15%, followed by chemical and cracker burn. 92.5% are unilateral involvement, and 7.5% is bilateral involvement. This is the clinical photographs of children having mechanical adnexal injuries, periocular forehead lacerations. This is bilateral and unilateral involvement with cracker burn. In our series, 45% had injured, in our series of injured eye, 45% had globe injury. In globe injury, the maximum is of open globe injury, followed by 40% had periocular lid injury, and orbital fracture is 18.6%. This is clinical photograph of children having cranioorbital fracture due to fall from height. This is a clinical photograph of children having ocular burn. It is a case of retained intraocular foreign body which present with 1 month history due to fall in the ground. It is removed with good outcome. At presentation, 44.9% had good visual outcome, 34.8% had visual impairment, and 20% had blindness. After treatment and follow-up, the visual impairment decreases to 29%, and the blindness decreases to 9%. On discussion, 5 to 10 years of age, 56.6% are more prone to ocular trauma. Males, 63.3% were injured, nearly twice as females. As boys are more active, adventurous and aggressive in nature and gets more freedom, home roads, streets and playground are most common place of injury. Majority, 60.8% of pediatric trauma are mechanical in nature. Similar to other studies, children suffers a higher percentage of open globe injury than adults. Prognostic factors of the visual outcome following ocular trauma, initial visual acuity, type of injury and severity. Penetrating injuries in general carry a poor prognosis. Visual prognosis in children is still worse than adult due to amblyopic problems. Finally, I conclude that sports and recreational activities are major cause of eye injuries in children. Study emphasizes on needs of health education and creating awareness among parents, caretakers and teachers regarding cause of severe ocular injuries, safety measures and importance of early presentation to hospital in decreasing ocular morbidity and its burden on the patient for future quality of life. These are my references. I am very much thankful to my mentor, Dr. R.P. Maurya, who guided me and allowed me to present this paper, which is part of his PhD thesis on ocular trauma. Thank you.
Thank you. Thank you, Dr. Swati. How many were penetrating injuries?
Sir, one, this is wooden intraocular.
No, how many of these were penetrating injuries? Mostly blunt, you are saying? No. Mostly blunt injuries or mostly penetrating? You want?
Some of his blunt and some of his pen.
Have you seen bow and arrow injuries in children?
Bow and arrow.
Bow and arrow injuries, especially during the Dussehra Diwali festival seasons. It used to be very common.
And then in units, that blouse hook injury, both in south and eastern part of India. Both
Have you seen those kind of injuries in this? Have you recorded any of these? So bow and arrow injuries were quite common in festive seasons of Dussehra Diwali because children tend to play with bows and arrows and they will hit directly towards the forehead or they lead to a injury to the eye. So we used to get a lot of these during our postgraduate days. Maybe the toys have changed because outdoor activities more of bow and arrows used to be there in our times. No? Thanks. Thank you. So with this we end the session. Thank you. Thanks a lot. I see my daughter.